rate on the upper channel and uterine contractions on the lower channel. They do this by attaching either externally and non-invasively or internally to detect the fetal heart rate in each uterine contraction. Labor is an inherently dangerous life event for a fetus and its mother. In the majority of cases, everything goes smoothly enough and ends happily. In a minority of cases, there are some problems. Electronic fetal monitoring is used to provide minute-by-minute information on the status of the fetus, accurate historical information on fetal status and the frequency and duration of contractions from earlier in labor, and insight into the stresses on the fetus and its ability to tolerate those stresses. Originally, electronic fetal monitoring was thought to be able to prevent such newborn problems as stillbirth, brain damage, and cerebral palsy. This hope proved to be overly optimistic. Unfortunately, and contrary to earlier thinking, most of the problems that lead to stillbirth, brain damage, and cerebral palsy are not intrapartum problems, but have already occurred by the time a patient comes into labor and delivery. Nonetheless, electronic fetal monitoring has proved so useful in so many ways that it has become a prominent feature of intrapartum care and indispensable for high-risk patients. Two forms of continuous electronic fetal heart rate monitoring are used, internal and external. Internal monitoring provides the most accurate information, but requires a scalp electrode be attached to the fetus and a pressure-sensing catheter to be inserted into the uterine cavity. Both of these require membranes to be ruptured, and both have small but not inconsequential risks. For that reason, they are usually used only when the clinical circumstances justify the small increased risk of complication. External monitoring usually provides very good information about the timing of contractions and the fetal response. External monitoring consists of belts worn by the mother during labor that record the abdominal tension, indirectly recording a contraction, and the instantaneous fetal heart rate. External monitoring has the advantages of simplicity, safety, availability, and reasonable reliability under most general obstetrical circumstances. However, it is subject to more artifact than internal monitoring and may not detect subtle changes and may not accurately record the information, particularly if the mother is overweight or active. Maternal blood flows to the uterus primarily through the uterine arteries. The arteries branch out once they enter the uterus and supply blood to the muscle cells of the myometrium and through the wall to the intravillous space. Once the maternal blood reaches the intravillous space, it is simply dumped into the space where it drifts about until some is drained off through the maternal venous system. Unlike the highly controlled capillary circulation, there is little control over this process. The placenta floats on top of the intravillous space, with its chorionic villi dipping down into the pool. Across the villus membrane pass oxygen, carbon dioxide, nutrients, and waste products. Some of this passage is active transport, for example glucose, some of it is facilitated, for example because of a pH gradient, and some of it is passive. Many factors influence uterine blood flow delivery to the intravillous space, including maternal position, maternal exercise, surface area of the placenta, hypotension or hypertension, and uterine contractions. Once maternal blood reaches the intravillous space, oxygen and nutrients must still traverse the villus membrane. If it's thickened, as with edema or infection, then transvillous transport of materials will be impaired, at least to some degree. The baseline fetal heart rate is normally between 110 and 160 beats per minute. This seems to be the range that the normal, healthy fetus prefers to keep itself well supplied with oxygen and nutrients. The heart can beat faster, but only at a cost of increased energy utilization that is normally not justified. The heart can beat slower, but if the bradycardia is prolonged, it can lead to progressive tissue oxygen debt. Tachycardia is the sustained elevation of fetal heart rate baseline above 160 beats per minute. Tachycardia can be a normal response to some increased need for oxygen. For example, increased fetal activity. Everybody's heart rate goes up when we exercise. Or maternal fever. With an elevated body temperature, all enzyme systems speed up, increasing the need for oxygen on a metabolic basis. It can also increase in the presence of more worrisome problems, including chorioamnionitis, maternal hypothyroidism, various drugs such as tocolytics or Vistaril, fetal hypoxia, fetal anemia, fetal heart failure, and fetal arrhythmias. Most tachycardias are not indicative of fetal jeopardy, particularly in the absence of any other fetal heart rate abnormalities. Bradycardia is a sustained depression of fetal heart rate baseline below 110. Most of these are caused by increased vagal tone, although congenital cardiac abnormalities can also be responsible. Mild bradycardia to 80 or 90 beats per minute with retention of beat-to-beat variability is common during the second stage of labor and not of great concern, so long as delivery occurs relatively soon. Moderate to severe bradycardia, in other words below 80 beats per minute, with loss of beat-to-beat variability, particularly in association with late decelerations, is more troubling and may indicate fetal distress requiring prompt resolution. The normal fetal heart rate baseline is from 110 to 160 and has variability. Variability means fluctuations in the fetal heart rate that are irregular in amplitude and frequency. This variability is further classified by measuring the peak to trough distance in beats per minute. Absent variability means no detectable fluctuations. Minimal variability means 0 to 5 beats per minute of fluctuation. Moderate variability is 6 to 25 beats per minute. Marked variability is greater than 25 beats per minute in fluctuations. Variability is normally controlled by the fetal brain through sympathetic and parasympathetic influences. Reduced variability normally occurs during fetal sleep and usually returns after 20 to 40 minutes. Reduced variability may also occur following narcotic administration, with fetal anomalies or injury, with hypoxia and acidosis in combination with such fetal heart rate abnormalities as late decelerations, tachycardia, bradycardia, and severe variable decelerations. Persistent or progressively reduced variability is not by itself a sign of fetal jeopardy, but in combination with other abnormalities may indicate fetal intolerance of labor. An abrupt increase in fetal heart rate of at least 15 beats per minute and lasting at least 15 seconds is called an acceleration. These usually occur in response to fetal movement and can sometimes be provoked by stimulating the fetal scalp during pelvic exam or by acoustically stimulating the fetus with a loud, obnoxious noise. Presence of fetal accelerations is a normal finding and indicates the fetus is tolerating the intrauterine environment well. In pregnancies less than 32 weeks, the height and breadth of fetal accelerations may normally be a little less, at 10 beats per minute lasting at least 10 seconds. If an acceleration lasts longer than 2 minutes, then it's classified as a prolonged acceleration. While unusual, it's of no clinical significance. Accelerations lasting longer than 10 minutes are considered a change in fetal heart rate baseline. A sinusoidal pattern is a smooth, sine wave-like pattern with a wave frequency of 3 to 5 per minute. By itself, this unusual pattern frequently has no significance, but in combination with a loss of variability is occasionally associated with fetal anemia. Let's consider contraction patterns. During latent phase labor, in other words prior to 4 centimeters, contractions may occur every 3 to 5 minutes and may or may not be painful. A normal contraction pattern in active labor shows contractions occurring about every 2 to 3 minutes and lasting about 60 seconds. If contractions are less often than every 2 to 3 minutes in the active phase, labor may progress more slowly, if at all. While less frequent contractions are the rule in latent phase labor, in other words prior to 4 centimeters, they are the exception in active labor. Coupling means that 2 contractions occur one right after the other rather than following the normal pattern. Usually, coupling is followed by a longer contraction-free interval. Tripling can also be seen where 3 contractions occur without any significant recovery time. If labor is progressing normally, coupling can be ignored, but coupling is often associated with dysfunctional progress in labor. In these cases, coupling can be treated with rest, hydration, narcotics, epidural anesthesia, or oxytocin. If contractions are persistently more often than 5 contractions in 10 minutes, this is called tachysystole. Tachysystole poses a problem for the fetus because it allows very little time for resupply of the fetus with oxygen and removal of waste products. For a normal fetus, tachysystole can usually be tolerated for a while, but if it goes on long enough, the fetus can be expected to become increasingly hypoxic and acidotic. Tachysystole is most often caused by too much oxytocin stimulation. In these cases, the simplest solution is to reduce or stop the oxytocin to achieve a more normal and better tolerated labor pattern. Other causes of tachysystole include dehydration, placental abruption, preeclampsia, and amnionitis. In cases of spontaneous tachysystole, increasing maternal hydration and placement in the lateral decubitus position may slow the contractions.